Welcome to our lecture on the lens and cataract. Over the next several slides, we are going to build a complete epidemiological picture of what is, quite simply, the single most important treatable cause of blindness on the planet. Cataract is unusual among the conditions we study in ophthalmology because it is both universal and curable. Every human being who lives long enough will develop lens opacification, and yet a 15-minute outpatient operation can reverse it almost entirely. That tension between inevitability and reversibility is what makes the epidemiology of cataract so clinically and ethically important. Let's get started. Now, let's talk about the epidemiological impact of cataracts. Cataract is the leading cause of blindness and of visual impairment worldwide, and that burden is increasing with aging populations, which makes sense as this is an age-related process. In terms of risk factors, elder age is the dominant driver, but it does not act alone. Tobacco use, diabetes mellitus, and ultraviolet exposure are the three most common modifiable environmental and systemic contributors that carry the strongest and most reproducible evidence. Beyond those, cataract has been associated with hypertension, prolonged corticosteroid use, genetic predisposition, ocular trauma, high myopia, and female sex. Dietary modification and nutritional supplementation have not been consistently proven to prevent cataract development. Next, in regards to surgery and public health, global cataract surgery rates are rising, but they track very closely with healthcare access and economic resources, which produces enormous international disparity. When surgery is delivered, it is highly cost-effective and is associated with improved visual function and reduced morbidity. Now, let us put actual numbers behind the global impact we just outlined. Cataracts are a leading cause of blindness globally, affecting more than 20 million people worldwide. That figure accounts for approximately 51% of all global blindness, with up to 90% of cataract-related blindness occurs in developing regions. Roughly 33% of the world's population experiences some degree of decreased vision, attributable to lens opacity. Among all causes of visual impairment, cataract ranks second, after uncorrected refractive error, which is itself a reminder that the two largest causes of poor vision worldwide are both readily correctable. In terms of etiology, there are four main categories of cataracts: congenital, metabolic, age-related, and traumatic. These categories will structure much of how we approach cataract clinically, because each carries a different workup, a different surgical consideration, and a different prognosis. In the United States, cataract affected approximately 24.4 million people in 2015, projected to reach nearly 39 million by 2030, driven almost entirely by population aging. Age-related cataract carries the greatest socioeconomic burden through sheer prevalence, while congenital cataract, though far less common, accounts for roughly 5 to 20% of childhood blindness worldwide and costs far more disability-adjusted life years per case. Before quoting prevalence figures, we need one caution that applies to every number in this section. There is no universally accepted cataract classification system, which makes accurate incidence and prevalence estimates genuinely difficult. Two studies can examine identical populations and report different rates simply because one used a stricter grading threshold. Compounding this, population-based studies differ in methodology, in how they define cataract, in grading systems, and in participant selection. Some count any detectable lens change, others only visually significant opacity. Some grade at the slit lamp, others from photographs. This makes comparison difficult. With that caveat in place, here is the United States picture. The dominant relationship is age. Risk rises with each decade, beginning around 40. By age and race, approximately 50% of white individuals have cataract by age 75, rising to about 70% by 80. At that same age of 80, approximately 53% of Black and 61% of Hispanic individuals are affected. These overall figures conceal important differences in which subtype predominates, which the next several slides will unpack. By sex, among United States cataract cases, roughly 61% are women and 39% men. Longer female life expectancy explains part of this, but as the previous slide noted, female sex is itself an associated risk factor. The Beaver Dam Eye Study conducted in Wisconsin in the late 1980s and 1990s, is foundational and frequently examined. Among participants older than 74, visually significant cataract affected approximately 38.8% of men and 45.9% of women, reproducing the female predominance we just saw within a single uniformly examined population. The incident subtype data carry the real teaching value. Nuclear cataract led at approximately 13.1%, cortical followed at 8%, and posterior subcapsular, or PSC, was least common at 3.4%. The trend cutting across all of it is that incidence of every subtype rises with age. Age is not selective, it drives all three. Does the beaver dam pattern hold across racial and ethnic groups? 2 studies say no. The Salisbury eye evaluation found nuclear cataract more common in white individuals, cortical cataract more than 4 times as common in black individuals, and PSC similar across racial groups at roughly 5 to 10%. The Barbados eye study reinforces this from another angle. In that predominantly black population, cortical cataract was the most frequent subtype, displacing nuclear from the top position it held in beaver dam. Barbados also showed higher prevalence in women than men, now the third independent dataset in this lecture demonstrating female predominance, which makes that finding well established rather than a methodological artifact. The takeaway is that most common cataract subtype has no single correct answer. It depends entirely on the population. Extending beyond the United States and the Caribbean, the cortical theme continues. Asian cohorts, specifically Singapore Malay and Handan, showed higher cortical cataract prevalence than white populations. Combined with Salisbury and Barbados, a consistent picture emerges. Relative to white populations, both black and Asian populations carry a higher cortical burden. The Italian-American cataract study in Parma provides the European comparison. For ages 65 to 74, prevalence was approximately 18% cortical, 6% nuclear, and 6% PSC, making cortical about 3 times as common as either other subtype. Compare that with beaver dam, where nuclear led at 13% and cortical trailed at 8%. The nuclear to cortical relationship has completely reversed. This is precisely the variability we warned you about in the initial slides. We turn now from age-related cataract to congenital cataract, which we noted accounts for roughly 5 to 20% of childhood blindness worldwide. Prevalence varies by country, but in the United States, there are approximately 3 to 4 visually significant cases per 10,000 live births. Clinically, congenital cataract are highly variable. It may be unilateral or bilateral, and may range widely in size, morphology, and density, from anterior polar dots needing only observation to dense white cataracts requiring urgent surgery. Visual outcomes, treatment course, and prognosis are therefore also highly variable. Having covered who develops cataract and where, we turn to why. Increasing age, as we mentioned, is the strongest and most universal risk factor. Beyond age, 3 environmental and systemic contributors carry the most robust evidence: smoking, diabetes mellitus, and ultraviolet exposure. Therefore, it is important to counsel patients on smoking cessation, strict glucose control, and the use of sunglasses in order to slow the progression of cataracts. Taking each in turn, smoking shows a dose-related increase in risk, and the effect is most pronounced for nuclear sclerotic cataract and PSC. Importantly for counseling, some lens damage may be partially reversible with cessation, which is a more encouraging message than patients usually expect. Diabetes mellitus is a well-established risk factor. This occurs because excess glucose entering the lens is shunted through the polyol pathway, generating sorbitol that cannot diffuse out, drawing water in osmotically and disrupting fiber architecture. Diabetic patients develop cataract both more often and younger. Ultraviolet exposure shows a consistent association across populations. Recall the elevated cortical rates in both Asian cohorts and the Barbados population. Ultraviolet light, which is particularly implicated in cortical change, is a plausible common thread. Several further risk factors are considered well established.
Hypertension is associated with increased cataract risk, along with prolonged corticosteroid use. Note that the association holds across all routes: systemic, inhaled, and topical. Ocular trauma, including ocular surgery, genetic predisposition, and high myopia are also major risk factors.
There are several inconsistent risk factors that have been noted across studies. Exogenous estrogen use is the first. Given that female sex is itself associated with cataract, hormonal influence is an attractive hypothesis, but the data have not been consistent enough to elevate it. Increased body mass index is the second, difficult to disentangle from diabetes, hypertension, and diet. Alcohol is the third and most nuanced, because the direction depends on dose. Interestingly, heavy use increases risk, while moderate consumption is possibly protective.
Nutrition deserves careful coverage because patients ask about it consistently. Early observational studies suggested possible benefit from vitamin C and E. The rationale was appealing. The lens is under lifelong oxidative stress and cannot replace its proteins. AREDS-1 tested that hypothesis with a formulation of vitamin C, vitamin E, beta-carotene, zinc, and copper. The cataract result was clearly negative. No reduction in progression to cataract surgery. An Italian trial of broader multivitamin and mineral supplementation produced a genuinely mixed result: decreased risk of nuclear sclerotic cataract, but increased risk of PSC. Putting this all together, supplements have not been consistently proven to prevent cataract.
AREDS-2 tested the addition of lutein and zeaxanthin, the carotenoids concentrated in the macula that absorb short-wavelength light, so there was reason to hope for lens protection as well. The primary cataract result mirrored AREDS-1, no significant reduction in progression to cataract surgery. There was one subgroup finding worth knowing. Patients in the lowest quintile of dietary lutein and zeaxanthin intake did show reduced cataract risk with supplementation. Supplementation may be only beneficial to those who were genuinely deficient. So the honest answer to the patient asking whether vitamins will prevent their cataract is that randomized evidence does not support routine supplementation, though an adequate diet remains sensible. The interventions we can genuinely recommend are the ones covered earlier: smoking cessation, glycemic control, and ultraviolet protection.
Now, let's discuss surgery as a public health intervention. Approximately 10 million cataract surgeries are performed worldwide each year, making it one of the most frequently performed operations of any kind. The determinant of surgical rate is not disease burden, but resources. Rates track closely with economic resources and healthcare access, the same structural inequality we saw when noting that up to 90% of cataract blindness occurs in developing regions. Developed countries reach up to 10,000 procedures per million population per year, with the highest reported rates in Malta, Japan, Australia, Argentina, and the United States.
Here is the other side, and it is stark. Many Asia-Pacific and African regions perform fewer than 500 surgeries per million per year, against the up to 10,000 achieved in developed countries, a 20-fold difference or greater. Some regions report as few as 150 per million, approaching a 70-fold gap. The disparity is entirely one of surgical capacity. The World Health Organization estimates that global surgical volume must triple to meet existing demand. Since current volume is roughly 10 million annually, that implies something near 30 million operations per year. The proposed benchmark is 3,000 surgeries per million per year. Notice where it sits, well below the 10,000 of the highest performers, but 6 times or more above the most underserved regions. It is deliberately pragmatic, representing the minimum at which a health system can keep pace with incident visually significant cataract, rather than watching the backlog grow.
We have established that surgery is under-delivered. The next question is what we gain when it is delivered, and the outcomes extend well beyond acuity. Cataract surgery is associated with reduced morbidity, and the mechanism is worth stating. Poor vision impairs depth perception, contrast sensitivity, and hazard detection, all of which raise fall risk. Harwood and colleagues in 2004 found that first eye surgery reduced falls and fractures, and also improved visual function and general health in women older than 70. A 2012 Medicare study of more than 1.1 million patients found lower hip fracture risk within 1 year after surgery. The implication is that counseling an elderly patient is about more than reading and driving. It also increases their safety.
The benefits may extend into cognition and survival, though here the evidence requires careful interpretation. Postoperative patients score higher on standardized cognitive assessments. The Blue Mountains Eye study in 2013 associated cataract surgery with improved long-term survival. The Women's Health Initiative in 2018 associated it with increased all-cause mortality. The slide gives us the resolution. This discrepancy is likely confounded by delayed surgery and baseline health status. Consider who has surgery late, often patients unable to access care, medically complex or frail, all of which independently predict mortality apart from the cataract.
Bringing the surgical picture home, cataract surgery is the most common outpatient surgery in the United States. Approximately 3.5 million procedures are performed annually. Direct annual cost is approximately $6.8 billion, making cataract surgery one of the largest single-line items in Medicare spending, which is why the cost-effectiveness data ahead matters so much for policy. Volume has risen steadily over 3 decades, reflecting both population aging and the improved safety, speed, and refractive predictability of modern phacoemulsification, which has lowered the threshold at which surgery is offered and accepted. There has also been an increased rate of second eye surgery within 3 months of the first, and the evidence supporting that practice is what the next slide addresses.
Whether the second eye adds benefit has an interesting evidentiary history, and the answer has changed. Early studies found no fall risk reduction with second eye surgery, and the reasoning seemed plausible. If the first eye already provides good acuity, the fellow eye might add only marginal benefit. A 2018 prospective study overturned that decisively, showing a 73% reduction in falls compared with the period before first eye surgery. That is a very large effect for any fall prevention intervention in the elderly. The benefit is attributed to improved binocular acuity and contrast sensitivity, which is mechanistically satisfying. A patient with one operated eye has anisymmetropia, unequal image quality and brightness between the eyes, and degraded stereopsis. This explains the prompt second eye practice noted on the previous slide and extends the Harwood and Medicare falls and fractures benefit to complete binocular rehabilitation. We close with the economic case, which draws together nearly every thread of this lecture. Cataract surgery is highly cost-effective. The standard metric is cost per quality-adjusted life year gained, where one such year represents a year lived in full health. For cataract surgery, the estimate is approximately $2,020 for the first eye and $2,727 for the second. Interventions costing up to $50,000 or $100,000 per quality-adjusted life year are routinely funding as cost-effective, so cataract surgery achieves its benefit at a small fraction of that threshold. Note, too, that the second eye remains extraordinarily cost-effective, which, together with that 73% reduction in falls, strongly justifies proceeding beyond one eye. Thank you for the attention on this short lecture. We will see you in the next one.